Good morning, everyone. Welcome to the 2012 Everett v. Fox Student Case Competition Finals Round. We will be starting with Team F. I just want to provide a couple of reminders before the team comes up to introduce themselves. For those of you all in the room, if you can just remember to silence your cell phones and communication devices and place those on silent. Thank you for the team. I'm going to give a couple of moments for the team to introduce themselves, and then we're going to allow our judges to introduce themselves.
Good morning. We're very excited to be here on behalf of Catholic Health Partners Mercy Health System's Strategic Planning Team. My name is Jonah Samaraju. This is Sid Chujajalu and Megan Bogany. We're here to talk about a very important topic, an integrated care delivery system for Northwest Ohio's dual eligible population. Thank you.
If we can have our judges introduce themselves, we'll start at this end of the table.
Jennifer Campbell Fitzgerald.
Denise Brooks Williams.
Pam Sutton Wallace.
Dale Oliver, HCA.
Herb Buchanan.
Yvonne Spence, Dignity Health.
Ken Page, Catholic Health Partners.
Thank you. So just a few reminders. The team will have 20 minutes to complete their presentation. Once you're ready to start, you'll indicate to the timekeeper, who's right over here, Phil, if you can raise your hand, that you'll be ready to start. You will receive a 5-minute warning prior to the end of your presentation time. Immediately following the presentation, we'll go right into the 10-minute question and answer session, and there'll be a 2-minute warning prior to the end of that time period. For our attendees and viewers, we want to remind, once the team has started their presentation, we won't have any movement in or out of the room until the end of the full time. Thank you.
Thank you. With that, we'd like to start our presentation. This is our agenda for today. I'm going to start us off with the background and the structure and then hand it off to my colleagues. First and foremost, we want to talk about our organization, Catholic Health Partners Mercy Health System. We want to make sure all the services we provide align with the mission and values of Catholic Health Partners Mercy Health System, to give back to the community to help those that need it the most. Our challenge is in Ohio, specifically Northwest Ohio. We have about 10,000 Medicare, Medicaid individuals. 40% of them are African American and Hispanic. The majority of them fall below the federal poverty line, and all of them are above the age of 65. These 4 hospitals have been identified to be part of the integrated care delivery system. Our ICDS is a capitated model between Ohio, Buckeye Health Plan, and Mercy Health System. We've chosen Buckeye Health Plan because they're a subsidiary of Centene Corporation. On a national level, Centene has been known to provide excellent services for the dual eligibles, and we have no doubt they'll be able to cater to the needs of our individuals in Northwest Ohio. We'll capture 5,000 individuals. During open enrollment, they will choose a health plan and a geriatrician, further ensuring that they are part of Mercy Health System. First, we wanted to understand where exactly does our dual eligible population live and who's taking care of them. 34% of them are living with family. This means that family members play a critical role in the coordination of care. We wanted to make sure that we address their concerns as well. We're going to implement the Zaret scale to assess caregiver burden. If our caregivers are at burnout or close to burnout, we want to make sure they have the resources available to take care of their loved ones. Next, we wanted to understand more about our organization, our population. Many of them have complex chronic diseases. This means they have a complicated medication regimen, easily lending themselves to medication reconciliation and medication adherence. These are the top concerns for ED, high ED readmission rates, and avoidable hospitalizations. To further emphasize this, last year alone, $2.5 billion were spent on only 182,000 dual eligibles in the state of Ohio. This leads us to the question, how can we more effectively manage our dual eligibles? Currently, the cookie-cutter approach is not working. This one-size-fits-all model has led to high episodic care, lack in continuity of care, and barriers to the geriatric population. So how is our model different? we propose a patient-centered medical home, specifically a geriatric medical home from the perspective of our geriatric patient. We want to understand their needs and their personal goals and embed them in their care coordination plan. We want to integrate their care into the community, and as mentioned, we want to make sure their family caregivers are taken care of so they can easily take care of their dual eligible. Lastly, we're going to implement innovative technology to combat the concerns of medication reconciliation and medication adherence. As I just mentioned, a lot of the care so far has been in the acute care setting. We want to focus on community-based care and recovery and rehab care for our dual eligible population. Our geriatric medical home is going to focus on quality measures, patient experience, care coordination, and health information technology. We're going to incentivize our physicians to be a part of the geriatric medical home through a bonus payment. If they successfully meet or exceed the quality metrics that we have assigned for our pay-for-performance, they'll receive a bonus payment for taking care of our dual eligibles. But we also realize there will be circumstances in when our dual eligible population will need acute care. And for that, we want them to utilize the geriatric emergency department. This currently exists within Mercy Health System's St. Anne's Hospital. It is the only geriatric emergency department in the region. They can address acute concerns such as fractures, renal insufficiencies, impaired mental status, but what's most important, it is a geriatric-friendly equipment to make sure that our individuals are cared for in their time of need, and they're also comfortable. This is our staffing model for a geriatric medical home and geriatric emergency department. I would like to highlight the additional employees. Our patient navigator is a part-time nurse who is bilingual. We want to make sure they're able to address the concerns of our diverse population. This person is available to our patients 24 hours a day, 7 days a week, either through a phone call or the Buckeye alert, a system my colleague will talk more about. We want to make sure, based on their acuity level, they get the right care that they need, whether it's in the medical home, the emergency department, or through other community resources. We also have a community coordinator who is a licensed clinical social worker. This person is a patient liaison and connects the patients with the right community resources, whether they're within Mercy Health System or through other community partnerships. Lastly, we have a case manager who is also a nurse and bilingual. This is the face that our patient can always rely on, and if they need any time of care, our care manager will take care of them. For example, if our patient leaves the inpatient setting, within 24 hours, our case manager will go into their home to make sure they understand their discharge protocols. We realize the first 30 days is critical to making sure our patients adhere to their care coordination. Our case manager will be there to assist them. Thereafter, our case manager will meet with them every other week. Lastly, our case manager coordinates care with all entities of the model, from the geriatrician to the nurse practitioner to the patient navigator to the community coordinator. This interdisciplinary team is critical for the success of our patients with their care coordination plan. I'd like to share with you the key findings we've just discussed and our recommendations. There's a fragmentation in the delivery of care currently, and we propose to have a geriatric medical home to take care of these concerns. We're going to improve coordination of care through a geriatrician. We're going to move patients from the inpatient setting to the outpatient setting to combat the concerns of high cost for the dual eligibles and high inpatient utilization. Lastly, we're going to use innovative technology to address the concerns of medication reconciliation and medication adherence. And with that, I'd like to hand it over to my colleague, Sid.
Thank you, Jonah. Let me start by talking about the Buckeye alert system. I'm sure many of you heard of the Life Alert system. Well, this is very similar to that, but it has been adapted to fit our model. Therefore, it puts you in direct contact with the patient navigator. It's very easy to use. You just put it onto your wrist or around your neck as a necklace, and you activate it with one single touch. It's also very convenient if you cannot get to your cell phone or landline phone. I want to run through two scenarios that are commonplace with our patient population. Scenario one, our patient, Ms. Smith. Ms. Smith is 78 years old. She was born and raised in Toledo, Ohio. She lives by herself, and she was just recently diagnosed with COPD. Ms. Smith wakes up one morning. She's not feeling herself. She's a little bit disoriented, and she's having trouble breathing. So for precautionary measures, she gets a hold of her patient navigator. The patient navigator, who is a nurse, assesses the acuity of the situation really determining whether this is an emergency or non-emergency situation. After speaking with Ms. Smith, he realizes that this is a non-emergency situation, but needs to be addressed. Therefore, he refers Ms. Smith to her geriatrician or geriatric nurse practitioner. Lucky for Ms. Smith, the geriatrician has open office hours later that afternoon, so Ms. Smith sees her geriatrician, gets stabilized, and sent home within the day. At that point, the geriatrician updates Ms. Smith's profile in Epic and notifies the case manager, who's specific to Ms. Smith, to follow up as needed. Let's take another scenario, a more emergent scenario. Ms. Smith is still our patient, and it's 5 years later, and her COPD has exacerbated. Ms. Smith wakes up this morning, and she's not doing well at all. She can barely breathe, and there's a tightening in her chest. Lucky for her, she has her Buckeye alert system to get a hold of her patient navigator. The patient navigator, realizing this is an emergency, accommodates for travel for Ms. Smith to go to the geriatric emergency department. When Ms. Smith arrives at the geriatric emergency department, she does not need to wait in line, she does not need to go through an exhaustive intake procedure, and she gets triaged and sent right into her room. Within a couple of hours, she's stabilized and ready for discharge. At this point, the case manager, the geriatrician, and the family are all notified in the update in care. Furthermore, the case manager must follow up within 24 hours, as this is protocol for any patient visiting the inpatient setting. The case manager must follow up within 24 hours. So, continuing with my story, the case manager goes to Ms. Smith's house. She realizes, oh my, Ms. Smith has not taken her medication in the last 7 days. This directly resulted in the fact that she went to the geriatric emergency department. Unfortunately, this is not an isolated incident with our population. Medication adherence and reconciliation is a major issue. Therefore, we propose to implement the use of the smart pill box. The smart pill box is exactly what it sounds like. It's a box around this big. It alerts you when to take your medication, what medication to take, how much of that medication to take, and if there's any complications with mixing certain medications. Furthermore, it also tracks adherence to the technological device. Therefore, the case manager, the family, and the geriatrician are all up to date with adherence to the patient's medication regimen. So who gets the smart pill box? Who gets the Buckeye alert? Who gets the case managers? In order to better understand our population, we've stratified our individuals into 4 different acuity levels. Level 1 being that of primarily healthy individuals, all the way to level 4, which is end-of-life palliative hospice care. Our major focus is on level 2 and level 3 individuals. Not only do they make up 80% of our population, but our services and interventions are geared towards these individuals, and they will benefit most from them. Another major aspect of our geriatric medical home model is that of engaging our patients and our patients' families in the community. We will help facilitate this process by our monthly newsletters, which actually are very well received in our community, our strategic outreach events, and the Cent account rewards account. The Cent rewards account is something that enables our patients to meet their personal goals. So let's take it back to Ms. Smith. Ms. Smith wants to get involved in a fitness program at her local YMCA to better herself and engage in healthy behavior. Every time she goes in for her exercise regime, she takes her card and she swipes it to show engagement. She accumulates a certain amount of points, and then she can take that card and redeem them at a local vendor, let's say a grocery store, therefore getting groceries. So what happened here? Ms. Smith engaged herself in healthy behaviors in the community, and she got a nutritional benefit as well. It's a win-win situation. So in summary, I've gone through 2 scenarios that are commonplace with our patient population. I've also discussed medication adherence, medication reconciliation, and emergency responsiveness technology. And lastly, honed in on the multidisciplinary aspect of meeting the needs of our patient population. With that, I will pass it off to Megan, who will talk about the health plan and the finances.
Thank you, Sid. Before we move on, I'll run us through some of our assumptions before we move forward to the financials. First, 50% of our dual eligible population will enroll in our model. Second, Buckeye will receive a capitated payment from CMS. 80% of this capitated payment will be allocated to providers. We're also assuming a 1% population growth in the state of Ohio each year. So first, let's understand how this capitated payment will move throughout the system. Buckeye will receive a payment from the state of Ohio and will keep around 15% for administrative costs. The rest will be allocated to the geriatric medical home, Mercy Health System, and other providers. The geriatric medical home will receive a coordination payment and a pay-for-performance payment from Buckeye. We'll also receive part of the Mercy Health System capitated payment. So let's look more closely at these three payments. The first, the capitated payment, will be around 12% of the Mercy Health System payment. The next is the coordination payment between Buckeye and the geriatric medical home. This will pay for the services our case managers and patient navigators provide to our patients. And the third payment is our pay-for-performance payment, which will be based off of 6 quality metrics that have been tailored to the geriatric population. So let's walk through this capitated model. Buckeye will receive around $3,000 per member per month from the state of Ohio. This will turn into $1,000 per member per month for Mercy Health System. Of this $1,000, the GMH will receive $160 per member per month. In year one, this $160 will turn into $9.5 million for the GMH. Our coordination payment, Buckeye will pay about $5 per member per month to the GMH, and in year one, this will total $300,000. For our pay-for-performance payment, it'll be based off of these 6 quality metrics that have been developed by the Measure Applications Partnerships for the dual-eligible geriatric population. This includes fall risk screening, care transition measures, and substance abuse screening. Now, in year one, we'll receive a bonus payment of 2% for setting up the infrastructure for these metrics. In year two, we'll receive a bonus payment of 3% for submitting our baseline data to Buckeye. And in year three, we'll receive a bonus payment of 5% for making targeted improvements in these areas. Now, with this payment model in mind, let's walk through the revenue. In year one, with a volume of around 5,000, we'll receive a payment of $9.5 million from Mercy for our GMH. Together with our coordination payment of $300,000, we'll have a total revenue in year one of $9.8 million. Now, walking through our expenses, in year one, we'll have a total operating expense of $10 million. This is composed of our salary expense of $4 million and our other expenses around $6 million. We'll have a total capital expense of $240,000, which will cover our technology and other geriatric elements we want to add throughout the system. This brings us to a total expense of $10.5 million in year one. Now, looking at our revenue and expense together, you can see that in year one, we'll have a net revenue of negative $600,000 due to all the comprehensive services we want to start providing our dual-eligible patients. However, by year three, our net revenue will increase to $256,000, and our operating margin will improve to 2.36%. This shows that by year three, our model will be financially stable. In addition to our net revenue, our model will also lead to cost savings throughout the health system. One of these areas is the emergency department. Currently, they spend about $1.7 million on roughly 4,000 dual-eligible encounters. However, through our model, we'll reduce these encounters to 800 individuals, and the ED will see a cost savings of $1.4 million, and this cost savings will continue to increase each year. In addition to our cost savings, our model will also lead to potential revenue for other areas of the health system. One of these areas is the Mercy Home Health Agency. Through our model, we'll be able to get about 10% of our dual eligibles that live at home alone to enroll in the Home Health Agency. This will give Mercy an additional revenue of $5 million each year. So I've walked us through our revenue and expenses and shown that we'll have a positive operating margin of 2.36% by year three. I've also shown that our model will lead to potential revenue opportunities and cost savings for Mercy Health System. Now I'll turn things over to Jonah, who will conclude our presentation.
Thank you, Megan. We'd like to bring it back to Ms. Smith and all dual eligibles. Through our ICDS, we've taken steps to address their concerns through our care coordination, through geriatric-friendly technology to combat the concerns of medication reconciliation and medication adherence. We've also decreased episodic care by using more of the outpatient services. We've done all this keeping in mind the mission and values of Catholic Health Partners Mercy Health System to help those in the community that need it the most. Also, we've included our family and caregivers because we realize they're pivotal to making sure our dual eligibles are on a healthy path. We do all this to make sure that our patients have better patient care and better patient outcomes. And with that, we'd like to open it up for questions.
So I have a question for you. I forgot to mention I pastor one of the largest churches in Toledo, and my senior citizens will be thrilled with this approach. If you could just help us understand your thought process as you channel all of these geriatric patients to one hospital, how you determined the after picture for patient volume, how you thought about staffing, fairly small staffing model for the ED, and then capacity. I assume that then all those patients who are going to be direct admitted will go to the same hospital. It's a 96-bed hospital. Just help us understand that thought process.
The thought process on exactly why.
Just how you thought about the reduction in ED visits, the staffing to accommodate that, and then now that all those patients are going from the other hospitals to the one hospital, I'm assuming, how you thought about capacity, how you knew what the inpatient utilization was going to be and whether 96 beds would work for that.
I think we're focusing on all 4 hospitals, but specifically for, I think you're talking about the emergency ED, correct?
Right.
We're talking about all of the 4 hospitals. So we realized that the actual 4 counties is about 1,000 square miles, so it's not too far from any one particular person that they can still come to the geriatric emergency department if they need assistance, because it's not too far of a distance. And we're also providing transportation for those that need the assistance to go there. But within our geriatric emergency department, the thought process that we came through was that there's about 4,000 individuals that are currently using the emergency department. So using the Pareto rule, about 80% of your population drives 20% of your cost, 20% of their population drives 80% of the cost. So those dual eligibles, we using the Pareto rule, we said about 80% of them, we can decrease their concerns. Because looking at the current individuals that are using the emergency department, these are preventable issues that come up, preventable due to medication reconciliation and medication adherence concerns, because these individuals are not exactly following the discharge protocols, which is why we have our case manager, which is how we came up with our number of individuals, 80% we can decrease coming. So 20% will probably really need to still come in because they are in acute care to be using the emergency department. Does that answer your question?
Sure.
I have a question, and it's a great approach, but my question is, the assumption is that these 4,000 people will enroll. How are you going to market, and how are you going to ensure that these people will enroll? How will you capture this population? Because I noticed marketing wasn't covered in this. And then second to that, too, you mentioned a cost savings to the ED of about $1.4 million. How did you come up with that as a cost savings for them? So how are you going to get them there, and then how the ED is going to assume they're going to save money?
So the way we didn't really address marketing as much, because the way we understand it working in Ohio is that since there will be 2 health plans, that most likely this population won't necessarily, not all of them will, I guess, take the initiative and enroll in a certain program. And so what happens most of the time is the government kind of splits it in half, and so 5,000 goes to this health plan and 5,000 goes to the other health plan. In addition, we think we offer enough unique services that we can really attract the patients to our system and to our model. We think that Mercy really has a lot of the services that they need, and that through our geriatrician and our case manager, they'll really want to use our system, and so that's the way we'll be able to keep them there, especially through our patient engagement and family engagement.
So you don't have a communication plan to let them know about this?
We do through our community resources, our community partnerships. That's kind of how we plan on, reaching out, I guess, to the community itself and letting our geriatric population, our dual eligible population, know about our model. That was our plan, to use our community partnerships, our community resources a lot, so we can start developing that partnership early on, and kind of keep this, the system, everyone moving throughout the same circle, kind of throughout the Northwest region. And then also, to answer your second question about the ED visits, what we did, my colleague mentioned earlier that kind of 80-20 rule. And so we expect through our model, since most likely 80% of those visits really aren't necessary for the ED, they're minor issues that can be handled in an outpatient setting. So through our patient navigator, we would be able to catch those early on and prevent a lot of those from coming to the ED.
I'd also like to add to my colleague's comment about the first part of the question. The community coordinator is a licensed social worker that will actually help facilitate the whole process of engaging the community and the patient within the community in order to help market our services. Because we, and I'm sure you can appreciate this, is that the referrals within the community are the strongest.
I have a question on your finances. If you look at your expense assumptions, can you talk me through what the technology line breakdown is and what the furniture is?
Well, for the technology piece, there is, as I've mentioned, the smart pill box and the Buckeye alert. Some people don't have a landline, for example, to put the smart pill box in there. We figured that we would incorporate those costs in our financial plan. And in addition, with the Medicaid waiver and the ICDS, the consolidated waiver, especially passport waiver, we think that with our technology allocation would be sufficient to meet our technological needs for our model.
And
So specifically, what does it cover?
It covers the Buckeye alert system, and also, in addition to, the Medicaid waiver is limited. So anyone who does not get that waiver, because it's also a very convoluted process to get that waiver, we would subsidize that with our expense, and also the smart pill box, smart pill box.
Oh, to add on to what my colleague has said about the furniture, we realize our geriatric emergency department that already exists really has all these unique features, and we think it would be really nice to kind of extend this throughout the health system, because we realize our geriatric patients will utilize other areas of the health system, other hospitals, other emergency rooms, and so just being able to make the entire experience, no matter if they can't come to the Mercy St. Anne Hospital, to make sure they receive some of the, the same type of, I guess, that they have the same type of experience.
As a follow-up to my colleague's question, I see that you do have the Buckeye alert there, but does that also include maintenance and replacement? And how many are you anticipating giving are you planning on giving these to every member?
We've stratified our population. I think it's on, you go to the stratification slide. For the top 10% and the bottom 10%, those are the healthy and the ones that are really sick. So we're going to hone in on the middle population of level 2 and level 3, because those are the individuals that are going to benefit the most from the Buckeye alert, the smart pill box, because they're the ones that are still using their medication and need some sort of regimen with it. And yes, we have, for our pilot program, we have accounted for the costs of the maintenance and everything. But I think that's kind of the beauty in having our tiered, or measure 1, 2, and 3, to make sure that once we set up our infrastructure, if we notice maybe in year 2 that there's some room for improvement somewhere else, we can go back and make the changes before we start evaluating ourselves in our pay for performance in year 3, to make sure that we can accommodate for those concerns, just like you mentioned.
Do your technology costs also include Epic licensing fees and system updates, et cetera?
It does not include the Epic licensing fees. We've assumed that the Mercy Health System itself would take that on, because they already have it. We assume that it's already in the ED, and so that's just something that will come along with the health system.
But you're expanding use of the system?
No,
right?
well,
So your case managers?
Yes, but the outpatient facilities already have Epic in place, and so they will most likely be using Epic themselves, and our case managers will already be in places that the hospital, they'll be with the outpatient, so they'll already have Epic use in those places.
Appreciate your, I'm sorry. Appreciate your focus on the mission and also the patient focus approach to care coordination. However, I did not hear a lot about how the care coordination and navigation community care worker would be linked to the primary care physician. You talked about having a primary care bonus. so that they will participate in, and obviously in your design. But would you talk a bit more about the linkage between your model and primary care, and is there capacity, primary care capacity in the community?
We realize primary care is probably the most critical component of this to make sure that our individuals continue on their coordination of care. So our case manager is the one that works really closely with our patient. They understand their daily needs, their daily concerns. This is the person that will link back to once a geriatrician. Like, we noticed Ms. Smith hadn't taken her pills for 7 days. Let's make sure we follow up with her. Like, have your MP talk to her, make sure there's a concern. Or maybe even we realize that it's a social concern. Maybe we talk to the patient, we talk to the clinical coordinator to make sure that they have the community resources available in the system. So our case manager is really the person that always links back to our primary care provider. And as we've mentioned before, we also have the patient navigator, the community coordinator that also work with our case manager. So really our case manager is the person that's once again going to that primary care site to make sure that we're helping our patients out.
And to add on,